Can everybody hear me? Mylene, can you hear me? Good. Welcome to Surgery Rounds today. It's my pleasure to introduce Dr. Mylene Arsenault. She's a family medicine. We sent a short bio through the link, I think yesterday. She has a lot of experience in telemedicine, and when I was asking around as to who could actually give us some good information about the do's and the don'ts of telemedicine and best practices, Dr. Arsenault's name actually came up. She's a practicing family medicine at the Herzl unit in the Jewish General Hospital. I was concerned that I was going to have her up at 7:30 in the morning, but she says she's quite used to it because she's also married to a surgeon. So that's so I'm not going to take up too much time introducing Mylene. I don't know if Dr. Feldman has anything that she'd like to add, but certainly one of the biggest issues we've had and the biggest transformations is also we've been doing all of this on Zoom and how we consult with our patients. So we're really looking forward to what you have to tell for us. And would you be able also to answer the chats at the end, Dr. Arsenault?
Yeah, absolutely. If as I will be sharing my screen, I usually don't see the chat, but perhaps we can collect those questions at the end, and I'd be happy to answer them for sure.
Okay, great. I think Dr. Feldman just joined in, so I think we're probably ready to go. Leanne, did you have any other comments that you wanted to make before we get started, or?
No, just to thank you very much for speaking with us this morning. I think this is a really important issue that everybody needs to learn how to do better. So thank you again for taking the time and the effort to come and speak to us.
All right, so I guess I'll just share my screen now. All right, are we good to go? Everybody seeing this? So first I wanted to thank Dr. LaChapelle and Dr. Feldman for their kind invitation. I'm happy to be here today and talk about telemedicine, as mentioned, has really become our new reality since this pandemic was declared earlier in March this year. So this is actually a presentation that I adapted from a course that we developed at the Herzl Clinic to help our family physician, but also our family med resident to be appropriately trained as they were all thrown in to do telemedicine quickly at the start of this pandemic. And as you will see, this talk is mostly based on documents that were produced by the CMA in conjunction with the CFPC and the Royal College of Surgeons, but as well from the CMPA. Oops. Oh, okay. So I just wanted to acknowledge my colleagues who initially helped me develop this module, Dr. Jarvis and Dr. Evans, but also wanted to mention how instrumental our Family Medicine Innovations and Learning Department were to put this together as a video, which is now online and available for all of the new incoming residents or any other physicians that want to take that course online as well. So I've tried to tailor this talk a bit to the needs of the surgical audience. As mentioned, Dr. LaChapelle mentioned, I am married to a surgeon, so I've seen a little bit of his challenge as well, as we're both sharing offices doing telemedicine at home. So anyways, I hope that this presentation will provide you with a framework and some tools to help you navigate this transition to telemedicine. So I have no conflict of interest to declare. So in terms of objective, I'll first introduce you to the key concepts of a telemedicine visit. I'll also introduce you to the professional and legal requirements you need to consider when you begin your telemedicine practice. I'll also share a tool with you called Telemedicine the Essential. This was developed at the Herzl Clinic, and it was again meant to help physicians who were new to telemedicine. I'll also review the benefits, challenges, and pitfalls of telemedicine, and I'll conclude this presentation by reviewing the CanMed roles that are important to the practice of telemedicine. So we'll start with the key elements of telemedicine. So basically, a fundamental principle of telemedicine is that regardless of the technology that is used to assess the patient, the physician is obliged to provide care to the best of their ability for that given patient during the current circumstance. So telemedicine acts as a complement to in-person medicine. It is not a replacement for face-to-face visit. So the two are not interchangeable. So during every encounter with a patient, we must decide if the issue that is being addressed is suitable to telemedicine or if an in-person visit would be better suited. But given also the current circumstance of the pandemic, we also need to ask ourselves if an in-person visit would put the patient's safety or the safety of others at risk. So telemedicine does certainly have limitations, and we will address those later in the talk. So as we are developing our expertise in providing virtual care, it's important that we standardize our core competencies, as this new paradigm is not a replacement for traditional clinical encounters, but it rather ushers in a new generation of medical practice. You know, we've seen some rapid changes due to the occurrence of COVID-19. And, you know, for example, I know my practice within a span of a few days has seen full-time practice in the hospital being moved to providing most of the care doing telemedicine from home. But after 3 months of doing this, I think it's important that we remind ourselves that although things have been changing very quickly, we must always remember that there's things that will never change, such as our duty of care, that we should always keep our patient's best interest in mind. And the standard of care should always remain the same, whether we provide telemedicine care or in-person care. So as per the Collège des médecins du Québec, telemedicine is defined as the practice of medicine at a distance using information and communication technologies. So the bottom line is the physician and the patient are not in the same location. There's basically 3 primary forms of telehealth communication. It could be over phone calls, it could be over video conference, or it could be over instant messaging, such as secure email or a messaging system that's integrated into your EMR. So these communications can occur asynchronously. That means not in real time. An example of this could be a patient and a physician exchanging a few emails over the course of a day. But please remember that although emails and text are very convenient to use, they're often also the least secure communication tools. You know, you can imagine that by mistake you enter the wrong email address recipient and it ends up, the personal medical information of your patient ends up in the wrong hands. But also the Collège prohibits the use of conventional email because they say conventional emails are not sufficiently private for exchange with patient. But if they recognize though that if you use an encryption software to protect your electronic message, this would be a reasonable safeguard and that would be acceptable. In terms of synchronous communication, these occur via video and they occur or over phone calls, and they occur in real time. But when doing virtual care, such as video calls, you need to make sure that your virtual care environment is equipped with appropriate tools for patient communication that are safe, privacy protective, and easy to use. So here's a word about these tools. So as per the Collège, again, des médecins du Québec, these tools and technologies have been approved and they're currently free of charge and available for physicians to use during this pandemic. So they've made available to us the Equinox platform, React, Microsoft Teams, and Zoom. I've seen most of us using Zoom so far, but it's important to note that only the Zoom enterprise license, or the one called telehealth, is appropriate to use for telehealth communications. Also note that, you know, as McGill teachers, we are all offered a Zoom license for teaching, but this is an educational license not the enterprise license, and it is not secure enough to provide consultation with our patients. Basically, the enterprise license ensures that the privacy issues are controlled. Also, if you're using an EMR, most of the EMRs have now platforms with integrated video conferencing, and these would be considered safe and acceptable as well. So these are some important concepts to know when you provide virtual care. So firstly, your assessment needs to be comprehensive and rigorous. That means if you feel that you need to see the patient, you should switch from a phone to a video conference feature. But if you feel that you need to examine the patient, you should not hesitate and book them in for an in-person visit. Confidentiality is essential. The conversation with the patient must be private. You and the patient must be in a safe, private location, and you must use a method of communication that minimizes the risks of a breach in confidentiality. Documentation is imperative. Your visit must be documented in your clinical record, the same way you would do it if you were to see that patient in person. You are liable in the same way you would be if you were to see the patient in person. And the better the communication will be, the less likely there will be confusion, errors, and litigation. So let's move on to the professional and legal requirements. As physicians, we must remind ourselves that whenever we provide care via telemedicine, we are held to the same ethical and professional standards during a teleconsultation as during an in-person consultation. And this is particularly in respect with professionalism, confidentiality, patient consent, record keeping, and patient follow-up. We must assume full liability and make our diagnosis with the greatest care using appropriate scientific methods when we are using virtual care method to assess our patients. So if some of us physicians are concerned about practicing outside our usual scope of practice, some of us have been deployed to different departments or to CHSL days, well, you can rest assured that the CMPA is there to protect us even during a public health crisis. But we can also rely on the CMPA for advice, support, and medical legal protection, especially during this COVID-19 pandemic. You can actually check out this website, the COVID-19 Hub, on the CMPA website, and there's a lot of good information about telehealth and in medicine and in the context of the pandemic. As we are using a lot more electronic communication, you know, we can think that this will improve our patient care, but will also enhance our patients' engagement in their care. But we also need to realize that it presents unique challenges to privacy, to patient privacy and patient confidentiality. So the CMPA also has published this great resource with 8 things that providers should know when using e-communications with patients. And perhaps it's a busy slide, but I will just highlight a few of these tips that I think that are really important. That the first one is that we must always make sure we protect our patients' personal health information. We should always make sure we consent our patient to the use of e-communication, and we should document this consent. We should always continually think that whether our tools we're using for this telemedicine is appropriate for our patient encounter. Always document our visit, and we should make sure that we give clear follow-up instructions. So we'll move on to the framework for a visit. So the first and foremost thing that we must do before we start a telehealth encounter is we always need to ask ourselves whether the issue that the patient presents is suitable to be addressed by telemedicine, or if it is inappropriate because the patient is too sick and would rather warrant an in-person visit. So we need to use our professional judgment to determine whether this video conference consultation is appropriate in the current circumstance, and whether it would allow us to provide or meet the standard of care. But you also need to consider that what would be normally inappropriate to be done over virtual care may be acceptable in certain circumstances, such as the current pandemic we are living. Remember that reasonable care is contextual. So, as the pandemic and the PPE situation is evolving, we might find ourselves at different points in the spectrum of care, depending on the circumstance we are in. So for example, if there's a future wave, our service offer might need to move in closer again to the virtual care end of the spectrum. But if we continue to do further relaxation of measures, our service offers may need to move again closer to the in-person care of the spectrum. There's other factors as well that may affect at which place we are on this spectrum, such as your own health or your own risk factors, but also the type of patients you're caring for. So you need to consider things like patient mobility or their clinical vulnerabilities, such as if they are immunosuppressed or on chemotherapy, for example, and that might help you decide which patient to keep out of the office for their own safety. But there's also factors related to your type of practice. So obviously, if you have a highly procedure-based specialty, it would be hard to offer most of your care via virtual care. But even if you can perform a procedure virtually and you have to bring them in person, nothing prevents you from doing some of the pre-work before they come into the office for this procedure. So basically, you need to adapt to each situation and use your best judgment. So, I reviewed a bit of the literature before preparing for this talk on the role of telehealth in surgical patients. And there was quite a lot of articles covering the past 2 decades on that subject. And there was this one that was recently published in April of 2020. And what I found was that it seems that telehealth was quite appropriate and effective in the pre-op setting. So provided that the patient has completed their imaging and their lab, then the surgeon could review the patient's dossier, their history, they could review it, do the counseling, the pre-op counseling with the patient, like the risks, the benefits, the alternative with the patient and their family over video conferencing before bringing them in the morning of their surgery for their in-person examination, as well as perhaps that signed consent. The other setting where it was also found to be appropriate and effective was in earlier detection of post-op complications. It is recommended, it was recommended by these authors though on these articles that you should consent your patients to post-op telehealth care as opposed to in-person care, perhaps obtaining a signed consent before they get discharged from the hospital. So in terms of scope of practice, here are some general examples of situations that could be appropriate to be used or to be dealt with over telemedicine. So some general infections like coughs and colds, uncomplicated UTI, sinus or minor skin infections. But remember again, if you're doing dermatology or skin assessment, you must have a high resolution video or photo to be able to see these conditions properly. A lot of counseling can be done over telehealth. In family medicine, we do contraception, sexual health or STI screening. I guess in your case, the pre-op counseling would be also something useful. Mental health conditions follow-up, but also the follow-up of chronic health conditions that are stable, such as hypertension and diabetes. I mean, obviously, acute conditions such as a patient presenting with an acute focal neurological deficit or acute chest pain, obviously that would be inappropriate and you would need to bring these patients in person. In terms of prescribing medication, under normal circumstance, the College has prohibited physicians to do any prescriptions of narcotics, benzodiazepines, or stimulants over telemedicine, but they have loosened these rules during the pandemic, such that now they would allow under certain circumstances, if you know the patient well and you are renewing a routine prescription. They would also say it's acceptable if you don't know the patient, but you have access to the patient's chart or to the DSQ treatment history. So these circumstances would be acceptable given the current pandemic, but you must always use your judgment and you always must make sure that you provide adequate follow-up. The college still say, though, that any new treatment of benzodiazepine, stimulants, or narcotics via telemedicine is forbidden. And for this, you need to bring the patient in, even during the pandemic. Cannabis prescriptions are always forbidden over telemedicine. So now, once that you have now deemed that your patient issue is suitable for a telemedicine visit, here is a recommended outline for your visit, and we'll go through each of these steps in more details. So firstly, introducing yourself. This is quite simple if you and the patient know each other, but if there's not an existing relationship, it's imperative that you explain to the patient who you are, and if you are doing a video conference, that you show them your ID badge over the video. We tell our residents as well that they must also inform the patient who the supervisor is for that consultation. Then we have to confirm the patient ID. So it's recommended that you ask at least 2 verification questions. So their name, their date of birth, or their Medicare card number. And if you're doing a video conference call, then you can ask the patient to show you their healthcare card. So in addition to these 2-factor identification, you must also check who else is listening. As we are not in an office with our patients, we don't know if there's anybody else in the room with them at home. So we need to make sure we ask them if there's anybody else listening to this call, and you should document this in your chart as well, these other people. It's important that we document our patient's location, and this is for 2 reasons. For emergency reason, but also for medical legal reason. You must confirm that your patient is in the province or the territory where you hold a license to practice medicine. That will ensure you that you have CMPA coverage. And it has occurred to me over the past 3 months that patients were stuck overseas, not able to come back to Quebec. So you have to make sure that you know where your patient is located so that you are properly covered by CMPA. So as per the college, you must obtain a patient's consent to do a teleconsultation. So you must make sure that the patient agrees to this type of consultation and that they understand its limitation. The CMP has also developed an electronic communication consent template that you can use, but you should adapt it to your practice and you should also personalize it. So basically what the patient needs to know is they need to know what the limits of the medical exercise, given the fact that you are performing their assessment over phone or over video and you're not seeing them in person, but also that there are possible breaches in confidentiality linked to the means of communication that is being used. But also you need to let them know how information will be stored on electronic media. Remember that we're not allowed to record patients without their consent. So once you have obtained your verbal consent, you must document it in the chart. If you are going to follow up or provide continuing care to your patient, at your next in-person visit, it would be recommended that you actually obtain a written consent as well. And please remember that a signed consent is not sufficient. A lot of us are using template. A discussion actually needs to happen between you and the patient. But don't worry, if you're having multiple follow-up, you don't need to have that extensive discussion each time. But it's important that you have that discussion and that you document it, and that you should also personalize a little bit your template so that it shows that you actually had a conversation about it with your patient. So once your consent is obtained, then you can now proceed to taking your history as in the usual fashion. In terms of physical exam, you can have the patient assist you in taking their vital signs. So if they have a scale, they'll be able to tell you their weight. If they have a blood pressure machine, they'll be able to take their blood pressure and tell you what they are. They can take their temperature. They can also take their pulse. If you're concerned about the rhythm, you can have them tap the rhythm for you. And a lot of patients these days have smartwatch, so you can also use those to get some of these vital signs. I find that I get a lot of information on video consultation, especially sometimes with my elderly patients, by just looking at their general overall appearance, their demeanor, but also being able to look at their environment. looking at them and seeing if they look lethargic, if they're in their PJs in bed, or if they're up and about, that gives me a lot of information. You can also look at signs of cyanosis or pallor. You can have them shine a light in their mouth, and you can examine their oropharynx. You can also have them palpate their neck and tell you if there's any lumps or areas of tenderness. In terms of rest exam, you can observe their rest rate. You can look for retractions or for increased work of breathing. When assessing the cardiovascular system, you can look for leg edema. You can instruct them to press on their lower legs and see if there's any signs of pitting. In terms of abdominal exam, you can look and observe for signs of distension. You can have the patient assist you in this physical exam by palpating their abdomen or by doing a renal punch to look for CVA tenderness. In children, you can also, or even in adults, you can have them jump up and down and look for peritoneal signs, for example. You can also perform some neurological exam. For example, you can easily do some cranial nerve exam. You can observe their gait, their tandem gait. You can do a Romberg. Like I mentioned before, if you have a high resolution camera or video, you can inspect the skin. You can look at your post-surgical wound and look for swelling or redness. And you can do some musculoskeletal exam by doing some passive range of motions or looking to palpate for areas of pain. So in case of emergencies, like for example, you're on the phone or on a video conference and you're concerned that your patient is acutely suicidal or they start having retrosternal chest pain, and we say that you should not hang out with the patient. So you should keep the line on with your patient and use a different line and call 911 and direct them to the patient's location. So this is why initially we said it's important to always know where your patient is located, which address they are currently. Then when concluding your visit, I like to summarize the visit with my patient, summarize the plan as well, because I like to make sure that we both understood the same thing so that I avoid any confusions. So it's important to discuss the plan with them and give the clear return instructions. I find that patients, especially these days with the pandemic, we are all functioning differently. Some of our offices are closed. Some of us are just doing telemedicine. Some patients are scared to come in to catch COVID. So I think it's really important to give them clear return instructions. And if you are not able to see them in person, then you need to make sure that you have a colleague that will be able to see them. And if they develop any of the red flag symptoms, that they can also resort to the emergency room. So again, always document your encounter with your patient. Like I mentioned, your consent needs to be documented, and also document the context. Again, because reasonable care is contextual and memory can fade over time, so it's important to leave all traces of your intellectual footprint. So this is the tool that was created at the Herzl clinic. We called it Telemedicine, the Essential. And that was, again, to help physicians who were thrown in to do telemedicine at the start of the pandemic. But this is basically what it looks like. And it really just walks you through each step of the telemedicine encounter. And this tool has been published on different websites, but it's also available on the McGill COVID resource website for anyone to use it. So let's move on to talk about some of the potential benefits, challenges, and pitfalls of telemedicine. And so we'll start with the benefits. So our goal when we provide care via telemedicine is that we maintain the same standards of care as with in-person care. So in terms of quality of care, we need to ensure that our telemedicine care provides all of these following elements. It must be safe. We need to make sure that virtual care will not increase the risks for a patient by deferring them an in-person visit. It has to be effective as well, meaning that we will achieve the same health outcome virtually as we would as an in-person intervention. It has to be patient-centered. We need to make sure that it meets the needs and the values of our patient. The patient should also be able to access virtual care in a timely fashion. And one of the significant benefits that we all have come to realize is that how telemedicine allows for good optimization of PPE use, but also help minimize waste of time. And finally, it's important that we ensure that virtual care remains equitable so that it benefits patients of all backgrounds. So more specifically, in terms of access to care, virtual care allows for an increase in access, especially because it provides care to patients from the comfort of their own home. The care is therefore more efficient, so that because patients don't have to travel to the hospital anymore to see their physician. But also from a pandemic perspective, it also offers patients to still receive medical care while they are respecting quarantine orders at home. So one issue that comes as a concern is for virtual care to fragment the continuity of care, but the occurrence of our electronic medical records in our units that are now universally accessible from any locations plays an essential role in preserving this continuity of care. And there are three core concepts of continuity. The first one is relational continuity. This means that we want to preserve that a patient and his provider can remain in contact despite location or distance. Then there's informational continuity. That means that we want the physician to be able to access prior medical information from a patient's chart, but also document the current care of this patient so that it is available for future consultations. And then there's management continuity. And this can be facilitated through the use of information technologies, such as secure messaging, to help manage the patient care more efficiently, but also jointly with other healthcare team members. Another important benefit that can be seen is on the use of resource. We know that resources are always important, but they're especially important now during this pandemic. So telemedicine will help us to be more efficient. We may have more time to help patients, especially now with all of the cleaning and the disinfection that we need to do in the room after we see a patient. So we may be able to see more patients virtually than in person. It's also empowering for patients as they are able to take a bit more charge of their own health. It will free up resources like nurses and support staff who can then carry out other tasks and duties. And having less patients come to the clinic in person likely has infection control benefits. So this is Dr. Gigi Osler. She's an ENT surgeon, and she's actually the co-chair of the Virtual Care Task Force. And I just wanted to share with you one of her quotes, where she said that virtual care has the power and ability not only to improve patient care, improve access to care, it can also make physicians' practice more efficient. The concept of forward triage can be beneficial, especially during the COVID-19 pandemic. This is the idea that RESP symptoms can be adequately triaged over video conferencing with a webcam. As RESP symptoms may be signs of COVID-19 infection, this will avoid patients with these symptoms to come to the clinic. As a matter of fact, we are currently at Herzl doing a telehealth visit on all of our patients before they come in person to make sure that they don't present any of the COVID-19 symptoms. So let's move on to the challenges of telemedicine. So there are several challenges to telemedicine that have been identified, and one example is the issues of communication and of the doctor-patient relationship. We know that nonverbal form of communication are important for developing a good doctor-patient relationship. And since virtual care does not offer the visual cues that an office visit provides to ensure the patient that they are actually seeing a professional, it's even more important that we emphasize our nonverbal means of communication when we provide telemedicine care to our patients. For example, it'd be important that you establish a strong eye contact with your patient by placing your camera in line with your eyes. or also by paying special attention to your tone of voice over the phone would also be very important. Webside manner is the way in which a healthcare professional interacts with patients via telemedicine, and it can be comparable to bedside manner if you use and emphasize main forms of nonverbal communication.
Because you keep doing it again. Every time you say you're sorry for something.
Oops, okay. So always remember to take the time to build a rapport with your patient, as this human rapport is as important as the medicine we provide our patient. Remember that communication is critical. It will reduce the risk of litigation. Now, there's also challenges linked to IT technical issues. Some potential issues could be having difficulty accessing the provincial health document, like the DSQ, at a distance. You may also experience internet connection issues, poor screen resolution, or the use of unsecure networks or portals. So virtual care has the potential to increase access to medical and healthcare, but it can also exacerbate inequalities in access to care. Access and continuity of care can be impacted by, for example, the variable access to technologies for some patients. For example, some patients living in remote areas or from a lower socioeconomic status, or also elderly who may have limited access to technologies. But patient competencies with technology may also be an issue. Again, elderly person may not be able to learn new technology as easily as younger patients and without any support. There's also patients with disabilities such as visual or hearing impairment, and these may have trouble benefiting from virtual care services to the same degree as other patients. Telemedicine may also be impossible or may exacerbate language barriers. And again, the physician's access to the medical record may be an issue. In terms of pitfalls, we need to remember that physicians are held to the same standards of care as with in-person care. And telemedicine should be supported by the same functional resources as with in-person visit. Technologies and workflow should be configured to ensure ease of use by patients and by providers. And we should also need to keep in mind that telemedicine is not a replacement for in-person visit, but it's a complement. And finally, we need to recognize the unique challenges of telemedicine regarding liability, confidentiality, and the storing of electronic patient information. And an example of this that I want to give is I've been getting a lot of insurance forms that I need to fill, and although we get them through secure email messaging and it gets uploaded into our EMR, I do need to print these forms at home. And in order to give it back to the patients, I usually need to upload it into a USB key or onto my desktop. So please be careful that these USB keys can get lost, so that if you have information, patient information, this may be an issue. But you should know that you can use encrypted USB keys, and that can help protect that. Or otherwise, make sure you delete all of these things from your desktop or your USB keys if you are doing that. So as July 1st is just around the corner, we are all getting a new cohort of residents, and that also need to be trained properly to provide care via telemedicine. So it's really important that we must first ensure as teachers that we are sufficiently familiar with best practices and with the tools used to virtually assess and treat patients. So CanMed roles for telemedicine have not yet been fully developed, as this is new and will evolve over time. But it's important that we develop our competency in all of these following CanMed roles. And some specific examples, for example, for the communicator role, is we need to make sure that we are able to communicate clearly with our patients using technologies so that we are able to gather all of the key information on history, especially since we are not getting those in-person physical assessment tips. An example for a health advocate role could be that we need to make sure we are able to properly determine suitability for virtual care for that patient. And in terms of manager and expert role, an example could be that we need to make sure we are able to adopt and manage the use of all of these new technologies to deliver and being able to deliver good patient-centered care. This is a guide that was developed by the Collège des Médecins du Québec to support us when supervising residents doing telemedicine in the context of the pandemic. Again, we need to make sure that before we delegate telehealth care to our learners, we as supervisors need to ensure that our residents are sufficiently trained and prepared to perform telemedicine well. The CMPA also tells us that before we delegate tasks to our residents, we should always ask us these questions. Is the task appropriate to be delegated to this learner given their level of training? Does this learner have the required knowledge, skill, and experience to perform the task? Is the patient informed of the educational status of the trainee? But also, what degree of supervision is required? So the location of the patient, the resident, and the supervisor relative to each other are therefore important to note. So there's a few configurations possible. So all the parties could be in different locations. And this has been imperative, especially at the start of this pandemic. Then there's also the configuration of on-site supervision, where the supervisor and the learner are in the same location, but linked with the patient at a distance. I think this is where we're moving at the Herzl with the new R1. We will be moving more with on-site supervision now. But there's also virtual supervision where the learner and the patient are together at the hospital and they're linked with a supervisor at a distance. So I guess this is more the example of the night or the weekend on-call resident. So under normal circumstance, though, outside of a healthcare crisis, the Collège des Médecins du Québec would recommend that the residents remain in their usual place of practice when doing telemedicine care, like at their usual clinic or at their usual site where they usually work. However, during extenuating circumstances like the current pandemic, if it is safer for everyone involved, then it would be acceptable that the resident work from their home, meaning like everyone, all three parties being at different locations. But be aware that this will increase the room for error when the learner and the supervisor are not in the same location. Also, the supervisor will need to decide if the duty of care has been met or whether the patient needs to be seen by a fully qualified physician to complete the assessment. We have to be careful and resist the temptation to rely on unchecked learner findings, and it's really important that we consider the level of the learner before delegating telemedicine care. So in conclusion, I guess these are the objectives that we've reviewed. And just wanted to perhaps leave you with two take-home messages. So first, I think I've mentioned it a few times already, but telemedicine is not a replacement. It's rather a complement for standard in-person care. And secondly, physicians need to continuously consider if the medical issue being addressed is in fact suitable for a telemedicine visit. You know, I think telemedicine was meant to become the way of the future, but COVID-19 has just really accelerated this implementation of telehealth in Canada and worldwide. So it's really important that we continue to learn and continue to invest to maximize the use of technologies, because I think telemedicine is most likely here to stay. So if there's any questions from the chat, I'd be happy to take them.
Thanks a lot, Dr. Arsenault, for a great review. I've been monitoring the chat and I don't see any really questions. yet. Maybe people will take some time to add some questions. My question, I just have a question in starting to use this a bit in the clinic is just to get your advice a bit about when you and a resident, let's say, are in the same location, what's the best way to, just in a practical way, to manage those? Usually in our clinic too, and sort of a corollary is the clinic I work in, the Zoom is set up in sort of our common area where we meet to discuss cases. It's not set up in like individual patient rooms at this point. So maybe if you could address both of those of how to actually, how to supervise when you're in the same location.
So we are using, for us, we're using a platform that is integrated into our EMR for video conferencing. So whether we are at home or we are together at the hospital in the same room, at the hospital, we all bring our own headphones and headsets that we connect with the computer. And so what we do is that we're able to do three-way video conferencing with the patient, where the resident and the patients are, sharing their sound and their images, but us as staff, we remain hidden with our video camera and with our sound, so we are able to just observe the whole visit, silently.
Okay, that would be more than what we would usually do, sort of in person, right? Is that what you do in person? You would watch a resident or student?
Well, yeah. So in person at Herzl, what we do is so we have a supervision room, and the residents are in their own examining room, and so we have a setup of video camera where obviously it doesn't always work. We don't have a 1-to-1 ratio. Like sometimes we'll have 5 residents for 1 staff. So obviously we're not able to watch every encounter. But we try to catch as much as possible these encounters. And so our rooms are set up with video camera, and we are watching them again with headsets in that supervision room. But because we are a bit more concerned with R1 coming in who don't have experience and are very fresh to starting residency, we are planning to do, at least for the first month, or for each resident, to perhaps do some one-on-one supervision and make sure that they are safely assessing patients via telemedicine.
Okay, there's a lot of interest in your slides, and there's a lot of appreciation for your presentation in the chat. And there was questions about whether you'd be able to share your slides some way. I'm sure we can find a way to do that. And then a question from Dr. Jarvis. Can you comment on what tools people need to do telemedicine?
So as I mentioned, I guess it was the one slide where it's really important that we use tools that are secure and private to do video conferencing with patients. So like I mentioned in the talk, like the college provides free licenses for physicians to do telehealth. So a lot of us are using Zoom licenses, but the only license that is approved by the college is the enterprise license, or the one that's called telehealth license. And this is really ensures that the privacy settings are respected. Basically is you need to make sure that the waiting room is enabled so that you can only allow the patient in one at a time. The screen sharing should be disabled as well.
Okay, Kevin, did you have any other questions?
Well, I had one question. It may not be completely, well, it is on topic. We've been doing telemedicine without knowing it for a little while now by texting names of patients and images of wounds and maybe even images of some x-rays and so on. So I'd just like to get your comments on that.
Exactly. So this is very risky. Again, I think if you are using text or email, you should not share any personal information. Like you shouldn't not identify anything of your patient on that text. The college prohibits its use. They would only allow you to share information via encrypted email. You also need to be careful when you are getting pictures from residents. Sometimes they get saved onto your clouds. They end up on unprotected servers. So the privacy issue, breach of confidentiality is really major here. So yeah, it's the other thing is, you know, I think when we do, even if we're using a private or encrypted email, like we have patients send us, when I ask patients to send me any documents, we have an encrypted email for the clinic, and everything gets sent to that encrypted email, and then it gets uploaded into our EMR. But you need to be careful that you don't have any sensitive pictures as well. I would bring these patients in and not get, because you can protect on your end, like your end of your email, but you can't protect what your patient's end is. Like they probably don't have an encrypted email. So you don't want their information being intercepted by anyone you don't want to.
Okay, thanks.
Okay, well, thank you, Dr. Arsenault. It was a great talk, very timely. I think we're all kind of, I know you've given it a lot of thought. Most of us are just dipping the toe in the water here, but I think you've given us really good practical advice of how to do this safely and effectively. I think it's here to stay. It's an important adjunct. You know, so I think this is really good advice. There was one last question, which is, does the hospital email considered encrypted? So if somebody sends you an email on your McGill address or your JGH address, it's not encrypted, right?
No, it's not. Like, so I know for our clinic, we have created our own encrypted email. So we have only one encrypted email address that we direct all of our patients to send their private information to.
Okay.
Yeah.
Good advice. Thank you very much for taking the time and helping us with all the knowledge you've acquired about this. I think this is a very important and hot topic. I think it's one of the COVID-19 side effects that's here to stay and for the better, I think. So thank you, and everybody have a great day. Thank you.
Thank you.